Welcome to the University of Maryland, Baltimore County. I'm Janet McGlynn, the Director of Communication and Outreach in our Office of Undergraduate Education. I'm here today with Dr. Mary Stuart, Professor and Director of the Health Policy Administration Program at UMBC. She is also a research investigator for the Department of Veterans Affairs. Dr. Stuart's doctorate is in Health Services Research from the Johns Hopkins University School of Public Health, and she is formerly the Director of Policy for the Department of Health for the state of Maryland. We share a long-standing interest in involving undergraduate students in the research enterprise. Mary, would you tell us about the focus of your research?
Thank you, Janet. It's a pleasure to be here today with you. My research has two major focuses. One is on chronic disease prevention and management, and particularly in that context on how we can improve care and reduce costs at the same time. And the second is on translational research. And in that context, I'm interested in best practices. Best practices are those services where we have empirical evidence to say they work. And the idea of translation is that we have a major concern because a lot of research, we prove it works, but it never gets into practice. So my focus is particularly on community translation, and that involves how we get these best practices in prevention and management of chronic disease out into the community, and how we cross the boundaries between the healthcare system and the community. Because with chronic disease, we're talking about people living with disease and disability, and a lot of their being able to remain independent and live functional lives and stay out of hospitals, which is how we save money, has to do with the services in the community as well as the healthcare system.
This sounds like it might be describing your training. You're trained in health services research. What is that exactly?
Well, health services researchers are trained to work in multidisciplinary teams, often with healthcare providers, physicians, nurses, physical therapists, and so forth. And we look at the organization and delivery of services and at health policy, and we look at how changes affect the quality, the functional outcomes, and access to care. So we're really interested in how we can improve things, how we can make it work better, and again, in my case, how we can also reduce costs at the same time.
I know you've had international experience and that you've conducted research on international best practices in preventing and managing chronic disease. Can you give an example or two and tell us a little bit about what you have learned from other countries?
Oh, that's a great question. I thank you. Most recently, probably the last 6 years, my research has been in Tuscany, Italy, and I've been very impressed with what the Italians have been able to do. They have well-developed information systems for administrative health data and very efficiently run local health authorities. And so I've been working with a local health authority in Italy where we've developed an exercise program called the Adaptive Physical Activity Program, or APA for short. And in that program, we're working with the frail elderly, people who've had stroke, people with Parkinson's disease or multiple sclerosis, and most of the people are suffering from chronic back pain, from osteoporosis, or other conditions just associated with frailty as they age. And there are now thousands of people in Tuscany who are participating in the APA program. It's well integrated with their health system, but the services are provided in the community in private gyms. So people pay for their own exercise class, just like you and I do when we go to our Pilates class. And they've pegged the cost of this exercise class to be just about the same price as a cup of coffee and a brioche. It probably would be a Danish, except this is Italy. So it's not a very expensive price for people to exercise, and it's been an enormously successful program. I've really enjoyed being able to be involved with the development and the evaluation of this program.
And that is something that translates back to this country?
Well, right now we're running a randomized clinical trial out in Howard County, Maryland, right near UMBC, and we're translating this into a U.S. context with research funding from the Department of Veterans Affairs. The program is being run in senior centers that are operated by the Department of the Office on Aging out in Howard County. Probably the other thing you should know is that people are really enjoying these classes because they form friendships. And so our program is for stroke survivors, and stroke survivors typically are very socially isolated, they're depressed, they have a hemiparetic limb, the ones in our studies, their leg isn't working so well, and it takes a lot of energy to drag that limb. And so by getting into the exercise program, they build up their aerobic capacity, they make friends, they have something to look forward to, and we hope that they also this will translate into more activity in the community. So we're looking at outcomes like free living activity and quality of life improvement.
And that all started from Italy.
That's right.
But you also mentioned to me that you have done work in Denmark.
Well, I've studied a number of countries, and Denmark that goes back a little bit further. But Denmark, probably 30 years ago now, Denmark started a very innovative program which has become an international best practice and has been actually replicated in Japan, among other countries. And in this program, the Danes actually quit building nursing homes in some of their communities, and they developed services to keep people out of hospitals and out of nursing homes and in their own homes. And in the most successful of their communities, they've significantly reduced hospitalization rates as well as institutionalization rates. So they have more people living in their homes, but their average cost per person is lower than it would be if they had people in nursing homes. Now, you may think that in the U.S., because we have so many people being cared for by their families, that would be less expensive, but it turns out it's not. The Danes, only 3% of Danish families have their elders living with them. They stay very involved with the activities of their aging parents, but they're not involved with the daily caregiving. And actually, the Danes started this in part because women were very active in their workforce, and they wanted to make sure that their workforce wasn't distracted by the heavy caregiving burden of the elderly. This is a real problem in the U.S. as people's parents age. You lose a lot of time when you have a parent who's sick, and I know this firsthand because my parents are now in their late 80s and 90s, and my mother just broke her arm, and my brothers had to take off work, and I'm going down this weekend to stay with her. So this is a way to improve the efficiency of your workforce as well as the quality of care for your elders. And the Danish elders, after they instituted this program, they did surveys of people, and they said, well, how do you like this? And by and large, people liked it, and they said, now I'm not afraid of aging because I know I'll get the support that I need. So this has been a very important program. And now you're going to ask me, so what about the United States? How did you translate that into the U.S.
That's what you do, right? Translate?
Well, this has been a challenge because the U.S. has a very heavily institutional-based system, and our families are spread out, and we just think it's normal to put people in nursing homes or assisted living, and as opposed to putting services out in the community. So the best that we've done, in my experience here in the U.S. with this program, is that probably 6 years ago I was speaking about this program at a conference in Maryland, and the director of the Office on Aging in Maryland, Phyllis Madachi, came racing up after I spoke, and she said, I'm just so excited. She was really breathless, and she said, I'm just so excited. This is exactly what I want to have in Howard County. How can I learn more about this? So we took a group of healthcare leaders from Howard County, and we went to Denmark, and we observed the Danish healthcare system with this group. And Phyllis came back and developed a chronic disease management initiative for Howard County, which has been quite successful. So it's different than what they're doing in Denmark, but it's really been a very innovative set of services. I have a private sector example for you too. Going back probably 15 years now, I was director of of health policy at the Maryland Department of Health, and we had funding from the Robert Wood Johnson Foundation, and my boss had asked me to figure out what systems of care would look like that could prevent or better manage the institutionalization and the high costs for the Medicaid population. We had found that 10% of people on Medicaid accounted for 75% of healthcare expenditures, and that these were largely people with chronic diseases. Now, 80% of healthcare expenditures in the U.S. are linked with chronic disease, but this 10% of people typically had multiple chronic diseases, and so they were challenges. In any healthcare system, they would be challenges, but those were the people we were really interested in because that's where the money was. It still is, in almost any insured population you look at, you see the same kind of distribution of costs, and the same type of people are causing these healthcare expenditures, or associated with them. It's a better word than causing them. So we identified best practices, and we took a group from Maryland, and we had some financial support from the Robert Wood Johnson Foundation. And on this team was the CEO of Lorien Health Systems, Lou Grimmel, as well as leadership from Hopkins and University of Maryland Health Systems. And we went over to Denmark, as well as 10 countries over 2 years, and we looked to see what was happening in these countries. And Lou Grimmel really impressed the whole team. And when he came back, he said that within 6 months he had changed his entire corporate strategic plan because he had seen what people wanted. He had seen the kinds of services that were good for people, and he wanted to be able to provide those in the U.S. So I'll give you an example of what he saw in Europe and what he did here. We were in Lyon, France, and they had a project for people who were respirator dependent because of chronic respiratory failure. These are people who are on ventilators. Mm-hmm. And the French in this region had developed a system of home care where they were able to keep these very sick people in their homes. And at first, Lou was very suspicious, and he said, all the services we've seen are in Lyon, and this is a big urban area, and they knew we were coming, and they've been selective about what we've seen. And he said, Mary, tomorrow I'm going to rent a car, and we're going to go out into the rural areas, and we're going to see what we find. And so we asked if we could go visit one of their rural hospitals, and they said yes, that would be fine. And so we got up early the next morning, and we drove out into the countryside, very beautiful countryside, mountains and vineyards. It was a lovely drive, and we got to this little hospital out in the country called Belcombe. And when we went into this facility, now you have to know that the French are not preoccupied with building newer and better facilities, and so they're really very proud of taking these old buildings and modernizing them and keeping them in use. So this was an old facility, and a lot of the equipment in it wasn't so shiny and bright as ours, but we had a team of physicians and leadership from Johns Hopkins and University of Maryland, and they were very gracious to us, and they walked us through the hospital and served us lunch, and which was excellent, I might add. And they introduced us to a woman who was in her 70s, and she had a tracheotomy, and it was through the trach that she used her respirator, and she had to be on a respirator maybe 16 hours in a 24-hour period. But she was very vivacious. Her hair was nicely done, and she had a turtleneck that covered this hole in her throat. And she told us herself how she had had tuberculosis when she was in her teens, and that she had been living in the community for years, and how she went out to the symphony, and she went to the symphony one day a week, and she went to the opera on other days, and how she went to the grocery store, and she couldn't carry her groceries up the steps to her apartment unaided, but if she set the groceries down, she could carry one item at a time. And her neighbors would come help her if they were home. They would help her carry them in. And she had assisted technology in her apartment so she could raise and lower her blinds. And of course, as she's talking, we're looking out the window at this, beautiful countryside, and we're thinking that she actually has it sounds like a lovely life, and she seems so vibrant and happy. And when we were done with that interview, Dr. Weinrich, who was on this trip, said to the French doctor who was talking to us, he said, "I don't believe that this woman has severe damage to her lungs. In our country, she would be in a chronic disease hospital. I mean, I don't think somebody with this serious reduction in capacity could be living in the community the way she's describing." And so they brought her x-rays in and held them up to the window, and the French doctors and the US doctors are there looking at the x-ray, and you can see on the x-ray, I actually have a photograph of this, you can see on the x-ray the damage to her lungs, and our doctor said, "Okay, we believe you." And when we went back for dinner that night, we sat around with our team, and the medical people there said, "I don't know how they do this. This woman would have been in a chronic disease hospital since she was 27 years old, and she's now in her 70s. And instead, she's been living out in the community." And Lou Grimmel said, "That's why we're here. We're here for our patients." He said, "That's what we're here to learn about." And Lou went home, and he began to develop programs in his chronic care and skilled nursing care facility, where he could wean people off ventilators and where he could help them transition back to home. And this was really radical at that point in time. That was a big deal. And he said, "Look, we can save Medicare money, and people can have better lives. I'm going to do this." So that's my private sector example.
Mm-hmm.
It was taking the government a little bit longer than it took Lou, but he did what he could do, and he did it beautifully.
Well, it seems like our community has reaped many benefits from your international research and travel. I know you've involved students in your research as well. Tell us about that.
Well, we run a health administration and policy program, and it seemed to me that these are the leaders of the future. I need to get them out to see these services. Now, some of this is self-serving because, I knew I wasn't getting any younger, and I could see that in Denmark, the way services were organized there, that's what I wanted things to be like when I needed the services. So I started thinking about how we could do this, and with the help of private donors, I've been able to get, over the last 10 years, I've been able to get over 100 students out to 10 different countries. So they've seen a wide variety of programs. We've had them in Denmark, Portugal, France, Switzerland, England, and the programs most recently, the biggest number of the programs, as you know, students have gone to Switzerland. The exciting thing about Switzerland for young people is that obesity and a sedentary lifestyle have actually become a public health crisis in this country. And Switzerland, in part because of the Alps and their beautiful geographic terrain, but also because of public policies such as public transportation, environmental protection policies, they have in many ways developed policies and practices and their culture that supports a healthy lifestyle. And so their chronic disease rates are lower than ours. They also have an excellent health system. So I've been very pleased to be able to take students to Switzerland and study the culture of policy and practice in that country.
I bet they were very pleased to go as well.
Well, we've had a good time doing that.
It just seems like this is going to be so valuable to us, as you keep saying, as we get older. But how did you get into this field to start with?
Well, now we're going back longer than I want to tell you, Janet McGlynn. I'll say, to be diplomatic, I'll say in the 1980s, the first job that I had at the Maryland Department of Health and Mental Hygiene, I was hired to staff a governor's task force on Medicaid cost containment. And this was right at the beginning of the precipitous rise in healthcare costs. Before that, the Medicaid budget had been very stable, and then suddenly expenditures started rising. And in the states, we can't print money. So we were told in no uncertain terms by the governor that we had to find a way to balance the budget. Healthcare was roughly 25% of the state budget, and the Medicaid program at that time was about 14% of the state budget. So this was a big deal. And we realized that we were either going to have to cut some very sick people off of a state insurance program, and these were people like roofers who had fallen off a roof. We're talking about the working poor here. Or we were going to have to find a better way to rein in costs. And that was where I began to be preoccupied with the question of how can you prevent or better manage high costs, and how can you contain costs and improve outcomes for people at the same time. So we were successful with that crisis in reining in costs and balancing the state budget. But this was a persistent problem. So for as long as I worked for the state health department, we were constantly looking for new initiatives that could help us in this. And probably 18 years ago, we realized that this figure that I told you earlier, that 10% of people were associated with 75% of the costs. And this included people in nursing homes who, we call it a spin down. You spin down your assets until you qualify for Medicaid. And Medicaid is really the major health insurance program in the country for the poor. So people were spending down into nursing homes.
So you're saying it's not just for poor people, but people who didn't used to be poor.
Absolutely, absolutely. The cost of nursing home care is so high that you can spend several $100s a day in a nursing home, and so you may have a nice little nest egg, but you run through that very quickly. So most of the people in nursing homes on Medicaid were not on Medicaid before they entered the nursing home. And this is why the Danish program was so important, because if you can prevent people from entering a nursing home, or if they enter a nursing home, if you can get them back home as fast as possible and put supports in there, even if they have Alzheimer's, help keep them in their own home, then you're able to keep people independent much, much longer, and this helps reduce the costs. And of course, people are happier. So in addition to the people who were in nursing homes, there were a number of people who were adults with chronic medical problems, and as I said, usually more than one. And there were also children who were high risk and suffering from disabilities and chronic diseases. So we looked at who we had in the program, and we used our Medicaid data to figure out who these people were and what they were costing us. And we began working with the research community at Hopkins and University of Maryland to understand more about what we could do for these people. But that was the point where we got this grant from Robert Wood Johnson to look at these integrated systems of care for people. And we developed something we called the High Cost User Initiative, and that actually UMBC played a critical role in implementing that initiative. And we still have Hilltop Institute on campus to this day working with Medicaid data. So we have Hilltop Institute. We took the best practices team. We have Howard County becoming what in my view is a model county in their services for the elderly.
Well, it sounds like we are very lucky that you are in this community and that you are training the next generation of researchers by involving undergraduates in your research.
Well, I appreciate you saying that. I think we're very fortunate that we've had the help of private donors to get the students out into the field. The workforce needs to meet the needs of an aging population are enormous. This is a critical issue for all of us, and I should say even young people, because it turns out that young people get sick too and they develop chronic diseases. And we have, when we talk about chronic disease, we're talking about substance abuse, mental health, as well as problems like diabetes or cardiovascular disease. And so the neurological diseases are particularly interesting to me, and the exercise programs, because just in the last few years we've understood that the brain is plastic, and so you can have an assault to the brain like stroke, and with practice, for example, our exercise programs, you can actually see the way different parts of the brain compensate for the injury. And of course, traumatic brain injury is something that we're particularly concerned about now with young people coming back from the war. We have more serious traumatic brain injury and larger numbers than we ever had before. This is an area where it's a big problem for young people and their families, and we're hoping to learn better ways of treating, we call it TBI, of treating traumatic brain injury, and of integrating people with TBI back in the community. And of course, we've heard newscasts on the amazing prosthetics that are being developed to help people with amputations in the war. But I'm very pleased with my research with the Department of Veterans Affairs. I feel very proud to be able to be an investigator with the VA at this point in time. And it's very gratifying to be able to see this work moving out into the community. And it's really exciting to see my students get interested in these programs, and to feel like we will have a better informed workforce because of this. So thank you very much for your interest.
This is wonderful. Thank you, Mary Stuart, for being a part of this program. For UMBC, University of Maryland, Baltimore County, I'm Janet McGlynn. Thank you for joining us.